Namaste बिटिया हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about various diseases that are related to the thyroid gland dysfunction. In the previous lecture, we have discussed about thyroiditis. Till now, we have discussed about the hyperthyroidism, we have discussed about the hypothyroidism, and we have also discussed about the thyroiditis. So in the last lecture, we have discussed about thyroiditis, different type of thyroiditis, acute, subacute, chronic thyroiditis, and Riedl's thyroiditis. I believe you must all have gone through the e-notes that I have provided and also consulted the book and also covered the questions that I have given to you in the e-notes. Now today we are going to start with goiter. Goiter, it is a very common presentation of the thyroid disorder, and this is very common in India. So you can see a lot of patients with goiter. And what is goiter? What are the etiological features? And what are the clinical features? What are the various investigation and how to manage a case of goiter? All these things we are going to discuss today. Goiter will be covered in multiple lectures. Today we are going to discuss about general goiter. In the next lecture, we are going to discuss about the multinodular goiter. So let's start with the goiter. What is goiter? Goiter refers to the enlargement of the thyroid gland. So whenever the thyroid gland is getting enlarged, it is known as the goiter. So you may see the thyroid gland enlargement in a lot of patients. So that particular condition is known as the goiter. Now, what are the different causes for goiter? There are a lot of causes for goiter, and the causes for goiter includes, number one, there can be biosynthesis defect. Biosynthetic defect. We are going to discuss about each and every point one by one. But first of all, let's try to understand the causes. Number one, we have the biosynthetic defect. Number two, we can have the iodine deficiencies. Iodine deficiency is a very important and very common cause for goiter in India. Third, we have the autoimmune disease. There are various autoimmune diseases that are responsible for the development of goiter. Next, we have certain type of the nodular diseases. Like we are going to discuss about the multinodular goiter in the next lecture. So what are the causes of goiter? For the causes of goiter, we can have biosynthetic defects. Number one, we can have iodine deficiencies, autoimmune disease, and the nodular diseases. So what occurs in the biosynthetic defect and the iodine deficiency? Now, in the biosynthetic defect and the iodine deficiency, these are associated with the reduced efficiency of the thyroid hormone synthesis. Biosynthesis means the body is not able to synthesize properly the hormones. And iodine deficiency is one of the important causes that is responsible for the non-availability of the substrate. So biosynthetic defect and iodine deficiency usually go hand in hand. They occur together in the simultaneously. And these are associated with the reduced efficiency of the thyroid hormone synthesis. And it is leading to the increased TSH. So because of the decreased value of the T3 and T4, inability of the body to synthesize T3 and T4, the value of the TSH will be increased, and which stimulates the thyroid growth. So because of this, there is increased growth of the thyroid gland. There are various presentations of the goiter. Goiter can be seen with multiple conditions, like in the Graves' disease. A goiter results from the TSH-R mediated effect of the TSI. We have already discussed the Graves' disease in the thyrotoxicosis topic 3 or 4 lectures before. So we have already discussed about the Graves' ophthalmopathies and different etiopathogenesis, how these immunoglobulins are affecting the thyroid gland. Thyroid stimulating immunoglobulins are affecting the thyroid gland, and why the goiter is seen. So in the Graves' disease, we can see goiter. In the Hashimoto thyroiditis, we can see goiter, and in the nodular disease, we can see the goiter. So what is happening in the, so we have 3 types of diseases. We have Graves' disease, we have Hashimoto thyroiditis, and we have the nodular diseases. So in the Graves' disease, the goiter is resulting from the TSH-R mediated effect of the TSI, that is thyroid stimulating immunoglobulins. In the Hashimoto thyroiditis, it occurs because of the acquired defects in the hormone synthesis. So in the Hashimoto thyroiditis, the goiter is occurring because of the acquired defect in the hormone synthesis, leading to the elevated levels of TSH and its consequent growth effects. So Graves' disease, it is resulting from the TSH-R mediated effects of the thyroid stimulating immunoglobulin in the Hashimoto thyroiditis. It is occurring because of the acquired effects of the hormone synthesis, leading to the elevation of the thyroid stimulating hormone and its consequent growth effects. The nodular disease is characterized by the disorder's growth of the thyroid cells, and it is often combined with the gradual development of the fibrosis. So in the nodular disease, it is characterized by the disordered growth of the thyroid cells, and it is combined with the gradual development of the fibrosis. The next variety is the diffuse non-toxic goiter. Diffuse non-toxic goiter, it is the diffuse enlargement of the thyroid gland. So there is diffuse enlargement of the thyroid gland in absence of the nodules or hyperthyroidism. As the name suggests, diffuse non-toxic goiter. What is happening in diffuse non-toxic goiter? We have diffuse goiter means diffuse enlargement. Non-toxic means it is not responsible for excessive secretion of T3 and T4. So there is no hypothyroidism. Hypothyroidism. So there is diffuse enlargement of the thyroid gland in absence of nodules. There are no nodules and there is no hyperthyroidism that can be seen in case of diffuse non-toxic goiter. It is most commonly caused by the iodine deficiency. So because of the iodine deficiency, there is diffuse non-toxic goiter that you are going to see. And this is more common in women as compared to the men. So diffuse non-toxic goiter, it is the diffuse enlargement of the thyroid gland, and it is not associated with hyperthyroidism, and it is mainly because of the iodine deficiency, and most commonly seen in the women as compared to men. The TSH levels are usually normal or maybe slightly increased because there is a reduced value of the T3 and T4. So it can be normal or it can be slightly, the TSH value can be slightly increased or be raised. There can be abnormalities at each step in the hormone synthesis. So there can be various abnormalities at each step in the hormone synthesis, and it includes iodide transport, thyroglobulin synthesis, organification, and coupling. That includes TPO and the regeneration of the iodide. So what is happening in diffuse non-toxic goiter? There are abnormalities at each step of the hormone synthesis. There are various iodide transport, thyroglobulin synthesis, organification, and coupling, TPO, and regeneration of the iodide that takes place. So in the diffuse non-toxic goiter, it is the enlargement of the thyroid in absence of nodules or hyperthyroidism. It is mainly caused due to iodine deficiencies and seen more commonly in women. The TSH levels can be normal or can be slightly raised, and there are abnormalities at each step of the hormone synthesis with the iodide transport, thyroglobulin synthesis, organification, and coupling, and the regeneration of the iodide. Now, what are the clinical manifestations of this goiter? So, in case of diffuse non-toxic goiter, how will this present in the patient? Now, there are different types of goiter that we have learned. Graves' disease we have already discussed. Today we are going to discuss with the diffuse non-toxic goiter, and multinodular goiter we are going to discuss in the next lectures. So whenever a patient of the diffuse non-toxic goiter is coming to you, then what are the clinical features with which the patient can present to us? As we have already learned that diffuse non-toxic goiter is because of the iodine deficiency, most commonly it is seen. So what are the clinical manifestations of the diffuse non-toxic goiter that you are going to see in the patients with diffuse non-toxic goiter? So the clinical features will include the thyroid function is preserved. So there will be increased size of the thyroid gland, but the thyroid function is usually preserved. So there is compensatory mechanism because of which the size is increased, and hence the thyroid function is usually preserved. Most goiters are asymptomatic. So the patient will come to us and will say that I don't have any problem, but the only thing is that my thyroid is enlarged, and otherwise I don't have any problem. So these are asymptomatic. The examination of a diffuse goiter reveals a symmetrically enlarged. So whenever you are going to examine the thyroid gland, then you are going to observe that it is symmetrically enlarged. It is non-tender, that is non-painful. On examination, the thyroid will be enlarged, symmetrically enlarged, and it will be non-tender, that is not painful on pressure. And it is generally a soft gland without a palpable nodules. So as the name suggests, non-toxic goiter, diffuse non-toxic goiter, so it will be enlarged symmetrically. There will be no nodules present, and it will be a soft gland without any palpable nodule, and it will be non-tender, means that it will not be painful. Now, if the thyroid is markedly enlarged, so if you come across the thyroid that is markedly enlarged, it can cause tracheal or esophageal compression. As we have seen in the radial thyroiditis, the compression was due to the fibrosis of the gland. That was an autoimmune disease. But here, this is occurring because of the iodine deficiency. And what is happening because of the enlarged size of the thyroid gland? You are observing the compression of the trachea and the esophagus. There will be substernal goiter, and it may obstruct the thoracic inlet. So the substernal goiters, because of the enlarged size of the thyroid gland, it can obstruct the thoracic inlet. The obstruction to the thoracic inlet, it is known as the Pemberton sign. Now, what happens in the Pemberton sign? The Pemberton sign refers to the symptoms of faintness with the evidence of facial congestion. So, enlarged thyroid can cause the obstruction of the thoracic inlet, and that particular condition will be known as the Pemberton sign. In the Pemberton sign, there will be symptoms of faintness with evidence of facial congestion. So the patient will complain of the symptoms of faintness with the evidence of facial congestion and external jugular venous obstruction. So what happens in Pemberton sign? There are symptoms of faintness with the evidence of facial congestion and external jugular venous obstruction when the arms are raised above the head. So you are asking the patient to raise the arms above the head, and then you are going to observe the features of faintness with the evidence of facial congestion. The face will be congested red, and there will be external jugular venous obstruction because of the enlarged thyroid gland. This will elevate the venous obstruction in the patient with goiters. The sign is positive when the bilateral arm elevated causes facial plethora. So if we are asking the patient to raise both the arms and there is facial plethora due to the obstruction of the thoracic inlet, then it is known as a positive sign. It has also been attributed to a cork effect. Cork effect, like the enlarged thyroid gland, it is acting as like a cork that is fitting here and is obstructing the venous return, that is causing the venous plethora or the facial plethora, that is resulting from the thyroid obstructing the thoracic inlet, thereby increasing the pressure on the venous system. Let me again revise the Pemberton sign. Pemberton sign refers to the symptoms of faintness with the evidence of facial congestion. So you are getting the symptoms of faintness and facial congestion and external jugular venous obstruction when the arms are raised above the head. It is used to elevate venous obstruction in the patients with goiter. The sign is positive when the bilateral arm elevation, it causes facial plethora. It has been attributed to a cork effect. So it is like a cork effect resulting from the thyroid obstructing the thoracic inlet and thereby increasing the pressure on the venous system. Now, how to diagnose a case of the diffuse non-toxic goiter? So whenever a case of diffuse non-toxic goiter is coming to us, we can diagnose it by the low levels of the serum T4 and normal T3 and TSH. So there will be low level of the T4 and normal levels of T3 and TSH. Why the level of T4 is low and the T3 is normal? Because of the conversion of the T4 to the T3. So because there is hormone synthesis deficiency, but there is presence of the normal T4 that is converting into the T3. Therefore, the T3 remains normal and ultimately the TSH remains normal. There are low urinary iodide level because the patient is not taking iodine properly. So there will be low urinary iodine levels, which will be less than 50 microgram per liter to support the diagnosis of the iodine deficiency. So we have low levels of T4, normal level of T3 and TSH because of the conversion of the T4 to T3. And there will be low urinary iodine levels that will be less than 50 microgram per liter to support the diagnosis of the iodine deficiency. Now, how to treat the case of the diffuse non-toxic goiter? Whenever a patient of diffuse non-toxic goiter is coming to us, how can we treat such patient? So the treatment consists of the iodine replacement because we know there is iodine deficiency in such cases. So we have to replace the iodine, and it includes variable regression of the goiter. So if such case is coming to us, then we are advising the patient to supplement iodine. We can advise iodide salt or certain medications that can regress the size of the goiter to normal. So the enlarged thyroid will shrink and come to a normal condition. If the shrinkage or normal condition is not possible and the gland is producing various pressure symptoms, then subtotal or near total thyroidectomy can be done for the cosmetic reasons. If the patient is saying that the patient is suffering from a lot of cosmetic problems, then subtotal or near total thyroidectomy can be done, and surgery should be followed by the replacement of the thyroid levothyroxine or the thyroid hormone. So if there is subtotal or near total thyroidectomy that is performed due to cosmetic reason, then lifelong supplementation of the thyroid hormone is needed. That is, levothyroxine has to be given. So this is all about the diffuse non-toxic goiter. In the next lecture, we are going to discuss about the multinodular goiter. So I hope you must have understood the session properly. In case of any query, you can consult the e-notes that I have uploaded on the portal, and you can also check for the books. So this is all for today. This session is powered by digital version 2.0, JAYOTI VIDYAPEETH University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.